While earning a Bachelor of Science degree of chemistry at the University of California, Irvine, Dr. Cornforth trained at Hoag Cancer Center in primary cancer cell culture. He then entered graduate school at the University of California, Irvine, and in the year 2000, after graduating with a PhD in experimental pathology in 2006, he returned to cell biology lab as a senior scientist to continue the work in cancer immunotherapy. He has published a wide body of work in that area. However, I had a little problem with that. I have specifically deleted references to his credits and papers because I can't even pronounce what he studied and written, let alone understand it. You'll see what I mean a little later on. In the summer of 2011, the program and its assets were purchased from Hoag Memorial Hospital by California Stem Cell, Inc. Dr. Cornforth was named Cancer Stem Cell Program Manager. He is focused on optimizing the protocols developed over 20 years at Hoag Hospital and to explore new avenues of research into autologous cancer cell therapy. Autologous. Now there's a word for you. I didn't know what that meant either. So I did a Wikipedia search on it, and it's the removal of stem cells stored and then returned to the same person. So now we're all educated tonight. And he also focused on providing cutting-edge cell-based immunotherapy for cancer patients using state-of-the-art technology employing stem cell biology. Dr. Cornforth's specialties are flow cytometry, RT-PCR, immunohistochemistry, primary tumor cell culture, dendritic cell biology, immunology, immune monitoring, and molecular biology. Wow, what a mouthful. Tonight, Dr. Cornforth's talk is entitled Prostate Cancer Cell Specific Stem Cell Therapy. Let me read that again since I screwed it up. Prostate Cancer Specific Stem Cell Therapy. Dr. Cornforth will present the most current information on the use of stem cells for prostate cancer therapy. While androgen deprivation has become the initial approach to advanced prostate cancer, novel therapies are being developed that may expand currently available treatments. Stem cell treatments are a type of intervention strategy that introduces new adult stem cells into damaged tissue in order to treat disease or injury. The ability of stem cells to renew offers significant potential for generation of tissues that can potentially replace diseased and damaged areas in the body with minimum risk of rejection and side effects. Essentially, chemotherapy is used to destroy the patient's own lymphocytes. The stem cells injected eventually replace the immune system of the patient with that of the healthy donor. Dr. Cornforth will provide oversight and expertise in the areas of tumor biology and immunology and in application of cell-based adaptive immunotherapy, clinical trials against melanoma, prostate cancer, and glioblastoma. It is with great pleasure and admiration that the Prostate Forum of Orange County presents to you Dr. Andrew Cornforth. While he's coming up, I might mention that we do have some envelopes that if you don't have any, if you want to give higher donation that you'd rather not put in the basket or checks or whatever, you put your credit card in here. These envelopes will be laying out on the tables later on.
Just check.
That one working?
There we go. Got it.
Okay.
Thank you. So thank you for that introduction. I appreciate the opportunity to come and speak before your forum. Sounds like you have some pretty impressive speakers who come and talk to your group. I'm proud to be one of them to come and actually speak to your group. As the introduction stated, my forte really is in immunotherapy, and maybe not specifically in using, and the word is autologous, it's really self, for using the stem cells to be put back into the patient, but more or less the cancer cells, using the patient's own cancer cells as a means of driving the immune response. So not so much the normal cells, but the cancer cells. There's a component of the therapy that I'm going to describe today that uses your own cells, but they're not necessarily like a stem cell therapy that you would get if you had high-dose chemotherapy, for instance, where they harvest a lot of your leukocytes all at once, and then you get high-dose chemotherapy, and then they give you those cells back to reconstitute your immune system. So the gist of what I'm going to talk about today is finding ways to target those cells that are most aggressive in cancer from an immunotherapy standpoint. So you're trying to target those cells that have the ability to metastasize and spread disease. So with that, I'll begin with this slide here. This is a slide from Hanahan and Weinberg back in 2000 that basically describes the characteristics that cancer cells have. And if you can't read them, I'll kind of go through them. There's just the ability to proliferate, just keep growing. There's the ability to obey growth receptors, suppressors. So these are like the conditions inside the body that would normally constrain an organ. Cancer doesn't worry about that. It just goes around it, spreads around it, goes through it. In the case of invasion of metastases, the ability to move through your circulatory system, the ability to move through tissues, and then replicative immortality. They just don't slow down. They just keep going. Most cells in your bodies will replicate for a certain point and then slow down and stop. Okay? And then angiogenesis, it needs a blood supply. And then lastly, resisting just the cell death, where the cells get mutated in your body normally. This happens all the time. Cells mutate, but they normally undergo suicide. There's a gene that's activated that says, oh wait, you have a genetic mistake. You need to eliminate yourself, and the body naturally does that. And cancer cells have figured out a way to avoid that. So the thrilling thing about the technology today is that we're starting to identify cells in certain types of cancers that have the ability to reconstitute an entire tumor from a single cell. So this cell could travel through your body to a new site and form a new tumor. That's the definition of metastases. We're starting to identify these cells, and we call them tumor-initiating cells, or cancer stem cells, or cancer replicating cells. There's a lot of different titles for them, and the definitions aren't locked solid yet, but we're really getting close to identifying these cells. And there's a lot of companies out there now who recognize that these cells are the ones that should be targeted for different therapies, either antibodies or drugs or chemotherapy. My approach is from an immunotherapy standpoint, as I've said. So I want to take those cells, get them out of the body, grow them up using actually normal stem cell biology, and then immunize the patient with those particular cells, those cells that are most aggressive, to mount that immune response. All the while not having the side effects and toxicities that you get from, let's say, a drug that targets normal stem cells that could wipe out, bone marrow and other parts of your body that rely on stem cells for regeneration. You wouldn't have that effect because I'm actually taking those cancer cells that don't have those normal antigens on them in great levels and immunizing the patient with those cells. So I like to start with this quote because this harkens back to the idea of using your patient's own cells, the very cells that make up your own tumor. Because each one of us is unique, your cancer in and of itself is unique. There isn't a common cancer cell for everybody. All of them are a little bit different. And I've got some cell lines to show you later on that kind of demonstrate this point. But this is a quote from Peter Menawar, who was a Nobel laureate in 1977, his work is well known for his work with graft versus host disease. And so the cure for cancer is never going to be found. It is far more likely that each tumor and each patient is going to present a unique research problem for which laboratory workers and clinicians between them will have to work out a unique solution. And this is becoming more evident today. You're starting to see patients get their tumors screened for certain mutations, and that guides therapy. The doctor wants to see, okay, are you mutated for BRCA1 or 2, or do you have an EGF mutation? I can give you these antibodies or these drugs. And we're starting to see sort of a pachinko effect where you will guide the therapy down by the different categories of mutations you have, and you can get down to almost a single person then in that case, where you're specifically gearing that therapy for the types of mutation that you find in those cancers. And now that we know, like the Human Genome Project is done, they're working on the Cancer Genome Project, and the power of this information will allow you literally to take your tumor cells from a biopsy, put them on a chip, and the doctor can get a readout of what mutations are in those cells, and then they can say, okay, you would be based on all of these clinical trials, you would be a good candidate for this series of drugs. And it's really remarkable. I take that to the next level where I say, well, I'm going to use the very cells that you got out to make your immunotherapy product for those cells. So, waste not, want. So as was indicated in the introduction, I now am an employee of California Stem Cell. Prior to that, I was working for Dr. Dillman at Hoag Cancer Center there. He's a very well-known oncologist in Orange County. His main research interests were in these patient-specific therapies. And I was a big part of that. I was in the laboratory growing the cells for these patients and coming up with the modalities to get cells from rare tumors. And, so I was the thrust behind finding new ways of getting cells that normally don't grow in the laboratory to grow in the laboratory and trying to provide patients with, let's say, renal cell, sarcoma, lung, ovarian cancers with the ability to receive the type of immunotherapy mainly reserved for people whose cell lines would grow easily. So I was sort of almost like a gardener. I would take cells and I would coax them and get them to grow, and take a long time. Sometimes we'd take months to grow them, but if the patient was available to get it, they would get it. And so Hoag was a non-profit institution, and all of the work there was supported by the Hoag Hospital Foundation. But about March of last year, Hoag decided from an economic and strategic standpoint that we really couldn't support this kind of therapy anymore. It was very expensive. It didn't impact enough patients. So Dr. Dillman and I sought a location to take the lab or transfer its assets to, and someone had introduced us to Hans Kierstead, also a very well-known stem cell researcher. He deals with adult stem cells and embryonic stem cell research. He's the co-director of the Bill and Sue Gross Stem Cell Research Center, the new research center at UCI. He was involved with the latest clinical trial involving stem cells and spinal cord injuries. So his technology is what is driving that research to try to repair the spinal cord with stem cells and get the mobility back. And he recognized in our modality, our patient-specific modality, in our cell therapy, taking cells from the patient, growing them in culture, trying to isolate the most aggressive phenotypes, he recognized the power of this and the utility of it, and he said, you know what? The way you're doing it now is great, but we can use the technology in regular stem cells to actually make these cancer stem cells grow faster and produce better products. And so he took on the program from Hoag Hospital. We still have a relationship with them in terms of being able to conduct clinical trials through their clinic. So we're happy to have this synergy going with Hoag Hospital, but it's a very exciting time for our company. We have a lot of new developments going on. So I'm going to just kind of go briefly through the immune system. I'm not going to give a whole course's worth, obviously, but some of this, I don't know if you're familiar with this, but probably a little background would be prudent. But these are the organs of the immune system. So there's, as most people know, there's lymph nodes and thymus and bone marrow. So your bone marrow is the central location for the stem cells that generate the immune cells in your body. Okay? And then your lymph nodes, cells that circulate through them, basically surveying your system, your body, looking for invaders. It's always looking for things trying to get into your body. So the cells of the immune system arise from cells out of the bone marrow and they go through a stem cell. So there's a single cell that can give rise to all these different cells. And I alluded to that earlier when I was talking about high-dose chemotherapy and how it wipes out your immune system. Well, high-dose chemotherapy can wipe out these cells too. So you need to get an engraftment of other cells to reconstitute all of these cells in your immune system. So in this case here, you have cells that branch off from this multi-potential stem cell that can become either in the myeloid lineage here or the lymphoid progenitor cell lineage here, where you have T cells, natural killer cells, and my favorite cell, the dendritic cell, which I'll talk about in a little later. But these are the players in the immune system that interact with cancer cells. So how do they interact with the cancer cells? So cancer cells, being what they are, aren't really normal cells. Your body has the ability to recognize tumor cells. It has the ability to eradicate these cells, and it actually will look for them. But your cancer has a way of hiding, and I'll talk about that in a minute. So it can attack cancer either through antibodies generated to particular antigens that are unique for those cancer cells, or macrophages can engulf pieces of the tumor and present them to these helper cells, would then secrete factors that stimulate other cells that can attack the cancer to grow. Or you can have what's called a cytotoxic T lymphocyte that recognizes the antigen on the surface of the tumor cell and kill it. Okay? So the way your immune system, or the tumor cells evade the immune system, is to provide basically an immunosuppressive environment. An environment where when lymphocytes arrive, they're told, no, this is a normal thing, don't bother, this isn't something you should be concerned with. Or they can downregulate factors on the surface of the cell that your immune system can recognize, like this molecule here called the MHC complex. Okay, so this is like the ID of the cell. It puts out this complex saying, I'm you, I'm really you. But if that is mutated or looks different, your immune system will eliminate it. In this case, it downregulates it, tries to hide itself. Okay? Or it can tell cells around it to secrete cytokines that tell your lymphocyte here that not to attack it. When it gets to the site of the tumor, it says, well, everything's normal here. I don't need to do anything. Okay? So that's, in a nutshell, that's the basic idea around the tumor microenvironment preventing immune response. Just tells your immune system that everything's normal, these are normal cells, let me be. Okay, so your immune system is essentially in balance all the time. It's constantly being attacked by the outside world, by bacteria and viruses when you prick your finger, when you breathe in antigens, but you don't want to be constantly reacting to everything. So there's a careful balance. And it turns out that in the case of cancer and autoimmunity, they're like the opposite ends of a teeter-totter. So in this case, if you had more autoimmunity, it means you have a really revved up kind of immune system that wants to attack a lot of different things that are normal in your body, you're less likely to get cancer. Or the reverse, if your immune system starts to get depressed, either because of, you're just, there's chemicals in your body and your environment that suppress your immune system, or you have to take immunosuppressive drugs because you're an organ transplant recipient, those kinds of things. You depress the immune system and your risk of cancer goes up. So it's a careful balance between your immune system's ability to recognize the cancer and its ability not to attack normal cells, because you don't want it to attack yourself. Okay, so how do we know that the immune system actually even plays a role in cancer and cancer therapy? Well, the immune regulation of cancer was really recognized by this guy, William B. Coley, back in the early 19th century, when he recognized that patients that were getting infections would sometimes have spontaneous regression of cancer. They would get like the flu or a bacterial infection, and their cancer would go away, it would disappear. And he actually isolated some of the compounds that were derived from bacterium, and he called it at the time Coley's toxin, and he was able to treat some patients and get some response. It was interesting, it was a good response. It wasn't overwhelming, it wasn't like he cured a lot of patients, but it was enough to realize that that cancer is an immunologically sensitive type of disease. Okay? And then, so like I said earlier, that immune suppression in cancer, so organ transplant recipients that have to take immunosuppressive drugs so they don't reject their organ or their graft, are higher risk for cancer. There's a famous a case where someone who received a liver or a kidney from a patient who had melanoma 20 years before actually developed melanoma in that organ. And it was like, well, that's impossible. It was 20 years before. They couldn't have. And it turned out they did a diagnostic test on it, and sure enough, that was a cell from that previous donor. So the immune system, because they suppressed it in the donor, those cells were allowed to come back and start growing again. It was really quite remarkable. So the types of immunotherapy that are taking place today. There's one type is really non-specific or systemic, where cytokines like this one called interleukin-2 and interferon alpha are given to a patient, and that essentially mounts an immune response that's non-specific to the body. It just wants to rev up the immune system and attack the cells that might be sensitive to the immune response non-specifically. Or when you want to do it specifically, you can generate lymphocytes like a CD8 cytotoxic T lymphocyte that's specific for an antigen on a tumor cell, and that's more targeted. Okay? So you have a lymphocyte where you take the lymphocytes out of the body and you grow a whole bunch of them in the laboratory, and then you give them all back at once. Okay? And so then there's an active specific type of therapy where you take an antigen, let's say, for instance, PSA. You can take PSA and try to immunize patients against prostate-specific antigen and get them to mount an immune response against any cells that are actually expressing that antigen. And that's what some companies are doing today. And I have some, I'll show you a little bit of that too. So the successful immunotherapy, though, must select an appropriate antigen or antigens to be effective. And the idea is that you want to target the antigens that are responsible for the spread of disease. You don't really want to target antigens that are on bulky, non-replicative cells that just make up a big bulky part of the tumor, because you're not going to eradicate the cells that form new tumors or new metastases. So that's where I am in my approach. I want to use only those cells that represent the most aggressive phenotypes, the cancer stem cells. Okay, so the way I've been proposing to do this, and the way we've done this in the past, and a lot of other groups are doing this as well, is with the help of what are called dendritic cells. So these dendritic cells are a type of cell in your body that is essentially moving around your body all the time, in your gut, in your lungs, and on your skin, surveying, sampling, looking for bacteria and virally infected cells. Basically anything where it can take that sample and process it and put it out on its surface to present to the immune system saying, here, I've found this antigen, do you recognize it, and should you mount an immune response against it? And it's constantly doing this. So what we can do right now is we can extract cells, monocytes, using a process called leukapheresis, which if you've heard of Provenge or Dendrion's therapy, that's the same process, and isolate the monocytes, incubate them in a cytokine cocktail that differentiates these, makes these cells become dendritic cells. So that's these cells here. And at this point, then, you give them the antigen. You give them what you think you're trying to immunize the patient against. So in the case of this diagram here, there's tumor extracts. There's whole tumor mRNA. There's an allogeneic tumor extract. So these would be cells from a donor, let's say. You don't have a supply of cells to use, so you take the donor cells of the same tumor phenotype and you would load them onto the patient's dendritic cells. Or synthetic peptides, where you make peptides in the laboratory and they're purified peptides and you load them onto the dendritic cell. Or you can use a viral vector to introduce a peptide into these cells. The idea is they're loading some kind of antigen to give to the immune system to mount that immune response in the patient. One thing that you notice that's missing here are whole proliferating tumor cells. And that's what I did. I take the cells, I take this tumor here and I bring it into my laboratory and I grow it up in big flasks, a whole bunch of cells, and I irradiate those cells and I actually give them to the dendritic cells and then use them. And the idea is that I'm isolating those cancer stem cells in the laboratory as opposed to using just the bulk tumor. Because as it turns out, cancer stem cells don't make up a large part of that tumor. They make up a small percentage of them. So you have to take the time and energy necessary to isolate them. So here's just a few examples of the type of immunotherapy that's going on today in prostate cancer. Of course, you're all familiar with Dendrion's product with the 3 cycles of GM-CSF, PSA-stimulated T cells, and activated dendritic cells. Then there's phase 3 clinical trials going on right now. There's Prostate, which is a pox virus that's subcutaneously injected to activate resident dendritic cells. So this TRICOM component is supposed to activate the dendritic cells that are already present in your skin. Because remember, they're in your skin, so they can inject them, the dendritic cells are attracted and activated by this compound, and then their PSA is their antigen. So they're using the PSA as the antigen to drive the immune response. Now, the Bristol-Myers Squibb compound called ipilimumab was just approved for use in melanoma, so it's likely it's going to be approved for use in other tumor types as well. So this is probably the most exciting thing that's happened in quite a while is this ipilimumab. And what it is it's a molecule that blocks the regulatory cells in your immune system. As I was demonstrating earlier about how your immune system is in balance, one of those cells is called a Treg cell. It's a regulatory cell that essentially tells your immune system to say, oh, slow it. You don't need to get so hyperactive. Well, this antibody will actually block that effect. It suppresses the Tregs, and now your immune system is just unleashed. Now, it can have some side effects, of course, because you have potential for autoimmunity, but you're essentially eradicating the tumor cells and everything at the same time. So it's likely that this will become an approved product when this clinical trial is completed, and will likely become part of the care that you see for prostate cancer as well. There's another drug that's come out that's similar to this one that goes against a different receptor called PD-L1, and it was one of the lead candidates at the American Society of Clinical Oncology this year. So what we're seeing is a change in the culture in the oncology community where they're more accepting of immunotherapy approaches. 10 years ago, 12 years ago, if I had gone to a laboratory or a doctor and said, oh, I've got this dendritic cell therapy that I want to try it in patients, they'd just look, what is that? I don't even know what that is. And, immunotherapy, though, that never works. They would shake their hands and shrug their shoulders. Now, the rooms for these immunotherapy protocols are filled in these conferences. Now, they pay attention to them. There's actually efficacy in clinical trials that's happening. And the most significant thing about it is that oftentimes, particularly in the cell-based immunotherapy protocols, there's really little to no toxicity, and that's the benefit. You're also seeing extended lifetimes without disease, or extended life with disease, but you don't have that toxicity, and I think that's a real significant benefit for the quality of life. Okay, so then this last one is an adenovirus, which is an interesting one. I put it on here only because they actually use it in a localized injection, so they'll inject it into the tumor bed, and it's a virus that will go into the tumor cell and lyse the cell, and then your immune system comes and cleans it up. And so it's getting all the cells that are in there, which I think is great. Instead of a particular antigen, where you may or may not mount an immune response to that, and that antigen may not be on the cell that might be driving metastatic disease, this is going to get a lot of that tumor, not only kill it, but then turn around and stimulate your immune system to say, I just killed all this and it died by a virus, and you should recognize it as an immune response and go out and find any cells that are like it and kill them too. So this one is really interesting. I'll be looking to see what their survival data is on this study. It's a very interesting concept. So now the talk is really about stem cells and mostly and somewhat about immunotherapy, but what are stem cells? So a normal stem cell, the ultimate stem cell, is a fertilized egg. Now, all of us here came from that one cell, and that one cell became 8, and then became this thing called a blastocyst. And if you were to collect these cells inside this wall, they can actually become all of these other cells in your body. So you can take those cells and make new nerves. You can take those cells and make muscle and blood cells. Just recently I was reading, and this is kind of an aside, but just today they released a study where a child who had a defect in his trachea, they took his stem cells, and these were adult stem cells actually, and they put them on the trachea, this stripped down trachea, and the child grew a new trachea around it, and then they reimplanted it, and 13 months later he's doing just fine, and he's got a new trachea. So it's really remarkable that you can engineer tissues, and you could see in the future sometime the ability to replace neurons and fix spinal cords, maybe grow a liver, kidney, who knows? The possibilities are endless, and this is really why we have, like in the state of California, a group called CIRM, or California Institute of Regenerative Medicine. There's real and solid reasoning to believe that using stem cell technology, you might be able to repair damaged tissues or replace organs. We're still quite a ways away from that, but the biology is there, the data is starting to come in, and it's really remarkable. Our own company is going to start a clinical trial in the United Kingdom dealing with spinal muscular atrophy. And if you know anything about that, that's a disease of infants who basically lose the ability to breathe because the innervation of the lungs is just not there. And so our idea is to reinnervate those babies and try to get them to breathe again using stem cell technology. So the cancer stem cell theory, the reason that I told you about normal stem cells and cancer stem cells is because they share kind of a similar trait. That is the ability to renew or regenerate or reform a tumor or a normal organ in the case of normal stem cells. So they're using the same kinds of biology and the same kinds of tricks to basically grow a new tumor or grow a new organ. So in the case of the theory is that a conventional therapy might kill all these non-cancer stem cells, leave behind the cancer stem cells, which can then regrow. If you were able to mount a cancer stem cell specific therapy, then you could actually knock out these cancer stem cells as well, and the tumor would essentially fade away. It'll just go away. So this is where a lot of the research in companies now is going, is trying to find a way to knock out these cells. We've knocked out these cells. We knock these cells out quite a bit. You see tumor shrinkage in a lot of drugs, but they become refractory and grow back. And it may be because of these cancer stem cells. A dynamic model is actually a kind of model that is still in the works, but some people believe that other cells in the tumor can actually become cancer stem cells. So if you don't eliminate all the cells, this one can decide, I can generate a new mutation and become more of a cancer stem cell and go on to regrow a new tumor. It really throws a wrench in the whole works of cancer stem cell biology. That guy at the beginning, Dr. Weinberg, he actually demonstrated this was possible in a breast cancer stem cell model. He took all the cells and he said, these are supposedly all the cancer stem cells on this side, and these are all the non-cancer stem cells on this side. And he put them in mice, and yeah, sure, all the tumors formed over here, and then he waited a long time for these ones over here. He waited what would be years for a mouse or a human, and a tumor formed. And he was like, well, maybe there was one that stuck in, right? One cell got in there. It turned out, no, they were completely pure. He took like 10 cells, and he could test all 10 and put them in the mice, and years later, a tumor formed. So there may be some validity to this. We'll see. But right now, I'm going with this convention. You target those cancer stem cells, and you can eliminate that tumor and prevent metastases. So what does that have to do with the normal prostate? Is the prostate a stem cell organ? Yeah, it sure is. There's a famous study by Isaacs and Coffey back in the 70s where they took rats, and they castrated rats, and then they waited 3 years and gave them testosterone again, and they grew back their prostate organ, just like that. No, not just like that. It took a little while, but the prostate grew back after they gave them androgens again. So what that meant was there was an androgen-independent cell in there that could hang out and wait for androgens to come back and reform the organ. So in the case of human prostate biology, so here's your luminal cells. Up here are these large columnar cells. These are the secretory cells. So out here is the opening in the prostate. This is where your prostate secretory cells will produce the fluids, the secretory fluids. And then you have these cells that are hard to see down here, but these are called the basal cells. And then you have another intermediate cell, which kind of shares this similar characteristics between these two cells. So the idea is that in the stem cell biology of the prostate cancer stem cell development, it's really not totally clear which cells are responsible, but they're getting closer to figuring this out. So there's this linear model where the basal cells represent the stem cell, which gives rise to your intermediate, and then that cell differentiates and becomes these two terminally differentiated, or cells that really can't do anything else but be these cells now. Either as neuroendocrine cells or luminal cells. Another one is that one theory is that this cell becomes a neuroendocrine, and then this one becomes either luminal or basal, and then there's an even more complex scenario. For androgen-independent growth, the idea is that, here's your mixed tumor cell population in a tumor or in a gland, and you do androgen deprivation therapy, and it'll work on the bulk of those cells that are androgen sensitive. But what will happen is you have these androgen-independent or androgen-resistant cells that will essentially repopulate the tumor. Now, are these the cancer stem cells? Maybe. So, some recent articles that came out that talk about what are the types of cells in the tumor that are the cancer stem cells, and what does that have to do with androgen deprivation therapy? So one group, this guy, Norman Maitland, who I would recommend as a speaker if you were so inclined, he's really good, identified tumorigenic prostate cancer stem cells. And then another group, really interestingly enough, and this is fairly recent, is that they identify prostate cancer cells that are self-renewing and long-term tumor-propagating cells that resist castration. So these have the same features as cancer stem cells, but they're the kinds of cells that make up the basal cell in the prostate organ or in the tumor. So these are androgen-independent cells that are the types of cells that will arise after androgen deprivation therapy. Okay, so what do I propose to do in my research? I've just described what I think the cells are. They're androgen-independent cells that arise after androgen deprivation therapy that are refractory and they're able to resist chemotherapy and they're able to spread. There's all the features of cancer stem cells. Well, my hope is to capture them, to catch them, and then grow them in the laboratory for a cell therapy product. And I'm going to do that by using the cells that can circulate in your blood. So here's your primary tumor here, and the cell actually has the ability to do what's called extravasation, or move out into the bloodstream, and then if it survives in the bloodstream, can find a new place or a niche to attach to and start growing a new tumor again. Well, it's got to go through your bloodstream to do that. And what I want to do is I want to actually capture the cells en route and then put them in culture and grow them. So circulating tumor cells are in wide use today in many different tumor types. Breast comes to mind immediately. And I believe there's uses for it now in prostate cancer. I'm not sure it's FDA approved, but it's probably pretty close to using the cell isolation technologies to essentially gauge disease response. So if you're under an active immunotherapy, they can measure these cells in your bloodstream and say, okay, your cell levels are going down. Oh, now they're going back up. Maybe it's time to switch gears and try something new. So it's a biomarker in that sense, where you could actually measure the response to the therapy a patient is under. And so there's also other uses for the cell. You could do a different marker analysis to look for, okay, are there different types of aggressive cancers that we could identify by a marker that might guide therapy? And the last part is this little guy right there, a little dotted line, because no one's doing this, is capturing these cells and putting them in culture. So what I'm looking for in the premise of what I'm going to write as a grant and propose as a study is to look for these circulating tumor cells, do peripheral blood draws of about 60 ml, that's about 4 tablespoons, and then I'm looking for patients who aren't currently receiving chemotherapy, but who are androgen refractory with rising PSA levels. So it's that window between after a patient is on androgen deprivation therapy and the PSA levels start to go up and before they start something new. It's a fairly tight window, but it's a window nonetheless. And I think that's where we can capture cells. And the reason I want to have to do it at that time is that the chemotherapy itself can actually damage the cells I'm trying to get, and then they don't survive the process of isolation. And I'll show you that in a minute. So how many cells do I think are circulating in prostate cancer patients? Well, this little diagram kind of gives you an idea. So these are log PSA positive CTCs of healthy male controls and female, you probably can't see over there, or prostate cancer patients, and you can see there's a considerable number of circulating cells in prostate cancer patients. And it's also relatively associated with PSA levels, but not perfectly associated. So it doesn't mean that you have more cells with a higher PSA, but there are definitely cells in there to capture. There's not very many, but that doesn't matter to me. If I get the right cells, I can get them to grow. So this is an example of the types of cells that are captured in circulating tumor cells and prostate cells. These kind of shadowy looking cells right here, these are your cancer cells that have been captured by this process and placed in a dish. These little guys here are probably red blood cells. So the quality of the cells, as I mentioned, I'm trying to avoid patients that are on active chemotherapy because it actually breaks down the cells and makes it, they're kind of fragile anyway, but I don't want to make them more fragile. So, and I wouldn't want to waste your time having a blood draw if I don't think I'm going to collect any cells. So about, in those samples, there's about 62% of them have circulating tumor cells that are identified. And then there was a correlation between the treatment and the quality of the CTC. So in radiotherapy or RT, there's more intact cells than someone having, let's say, Taxotere down here, and there's only a couple of cells that are intact. So this is a device that actually captures the cells and puts them on a chip and then counts them. And you can actually see each and every one of them, and it's all automated. The problem with this device, and I tried it in my laboratory, is that it fixes the cells. It essentially stops them in time, and then they don't grow. They're not useful in culture. They're great for enumerating and counting, but they're not good for actually cultivating the cells. So how do I propose to do this? I'm going to use an antibody that can recognize a protein on the surface of the tumor cells, and that antibody is connected to a magnetic bead, and then I can use a device like this, where the fluid is taken up and it's placed into a column, which then a magnet is placed against that. And all the cells with beads on them get pushed against the magnet and held there, while all the unlabeled cells go through. And then I'm able to collect the labeled cells and place them in culture. And I've actually done this on a trial basis. So I took some normal cells, and I took a model cell line, and I just did some dilution assays, and I put them through the column to make sure that they survived and everything was good. And I was able to form these little colonies of cells, as you can see, that will proliferate. So here's day 3, there's a collection of cells here, and then here's the same cells 10 days later. Now this is a model cell line that's meant to grow in culture, so it's not terribly difficult to do this, but it's a proof of concept that we can collect the cells through the column, put them in a dish, and get them to grow. Now, can I do it at really low numbers? This is going to be hard to see with this projector, but what I did was I took blood and I spiked in this model cell line with varying amounts of cells, and then I added a feeder layer of cells. These are normal prostate stromal cells. I added that layer because cells, like other cells around them, those cells feed them factors in a way that allows them to proliferate and grow. If I try to isolate a single cell with nothing around it, it really doesn't do anything. But in this column here, these are 10, 100, and 1,000, and then 10,000 cells put into the blood per ml. And you can see in this picture up here, and I'll blow it up, here's just one little cell right here, and then here's the same cells in this little colony here that have started to grow because of these stromal cells around it. So I'm optimizing the conditions to capture a few cells out of the blood, put them into this feeder layer of other cells, and get them to form colonies. And then as they get bigger and bigger, I can take them out and transfer them into new dishes. Okay? So the premise of the feasibility study that I'm working on is that a patient will routinely go in to get blood draws anyway, and then I would just ask for a couple of extra tubes if they fit that characterization of androgen refractory but not currently receiving chemo, could be having radiotherapy with a rising level of PSA. So the idea is that those are the patients that we're going to ask to give us some blood so that we can try to isolate and grow those cells and see if we can do it. Because right now we're still in the stages of feasibility and not in the phase of being able to actively produce a product yet. We have to work on optimizing it and making sure that we can do it fairly routinely. And all of this is based on the studies we did at Hoag Hospital with Dr. Dillman, primarily in melanoma patients. And I'm going to kind of describe some of the results of those clinical trials fairly quickly here. So the reason we're going after circulating cells in prostate cancer is that it's actually really hard to get any kind of tumor biopsies. It's not an easy thing to do a bone biopsy or something like that if the disease is in bones. So that's why we thought the accessibility of the circulating cells was a good way, a good strategy to approach for this type of disease. In the case of melanoma, it's not, because there's cutaneous nodules in your skin that you can excise out. You can just cut them out. And we can bring those into the laboratory and I can process them and put them in culture and then purify the cells into this highly pure population of cells and then store them and then have the patient come in and do the leukapheresis and make the dendritic cells, load them with these purified cells, and then treat the patient with a series of injections using all the patient's own cells, tumor cells, and dendritic cells. And as I mentioned before, how each of us is different, how each tumor cell is different. Well, here's an example. So these are all melanoma cell lines, and just grossly, you can see they're all different. They all look different. They all have different morphologies, meaning shapes. They share some similarities. They might have 2 ends or 3 ends, or they might be more round. But typically, I'd be growing these cells, and they're all a little bit different. And I would have to actually treat each one a little bit differently. I would decide we're going to go this direction with this cell line, we're going to go that. And it was a very unautomated, very skillful type of process. And we're actually actively working right now to make this more uniform and using the stem cell biology at California Stem Cell to make this less skillful and more thorough and hopefully more successful and shorter. It took sometimes up to 18 months, 20 months to develop one of these cell lines. And I've actually treated patients as far out as 22 months just by being patient and getting the cell lines to grow. So what are these cells that are growing in the laboratory and what do they have to do with cancer stem cells? In the case of melanoma, there were 2 markers that we identified. One that was associated with one that promotes metastases. So that's the ability of cells to be able to leave the tumor, get into the bloodstream, and form a new tumor. So there's a particular marker that identifies cells with that capability. And it turns out that cancer stem cells, not surprisingly enough, also have that marker, but they have another unique marker that I can identify that allows me to actually gauge the purity of the samples during that processing. So here's your bulk tumor here, where just a mixture of different cells that are in the tumor right at the beginning of the cell culture. So just a single cell suspension of lymphocytes, normal cells, tumor cells placed in a dish. And then over time, with the techniques that I use in the laboratory, I'm able to start to purify these cells and then end up with a purified cell line. And so these are the cells we're using. And so these cells are highly expressing these 2 particular markers, one for invasiveness and one for stemness. So what they represent is the most aggressive phenotypes within that tumor. Okay, and so here's the results of 2 clinical trials we recently conducted. One was conducted in 2000 and 2006 that took these cells, loaded them on the dendritic cells, and then immunized the patients with them. So the dotted line here represents the survival curve for patients with stage 4 melanoma. And after about 5 years, only about 10 to 15% of the patients remain alive. So in this particular figure here, this is a single-arm study where we only use dendritic cells and tumor cells. And this red line here actually represents progression-free survival, and this is overall survival here. And so you can see that after about 5 years, we still have 50% of our patients still alive with a sample size of 54 patients. That's a significant improvement over the typical standard of care survival rate of about 10 to 15%. We wanted to make sure, though, because of the way we conducted the study, by growing tumor cells and the patients having to get treated at different times and waiting, that we didn't somehow bias our results, that this wouldn't have happened anyway, based on the idea that the patients, well, they had to wait for their tumor cell to grow, they would have done better anyway. And so we decided to do a randomized study where we took patients and we grew tumor cells for them, and we gave them either the dendritic cell tumor cell combination or just the tumor cell alone. And so you can see here the blue curve is the dendritic cell tumor cell culture immunotherapy by itself, and then here's the tumor cells only curve. All the patients had to wait the same amount of time. They all get treated exactly the same way, except you can see that there's a dramatic difference in the two curves. The patients receiving those dendritic cells along with those purified cancer stem cells did much better in this study than just receiving just the tumor cells alone. So it's a necessity to have those dendritic cells in there to activate and mount and get that immune system going in this therapy. What these are is it's a subcutaneous injection of the dendritic cells and the tumor cells admixed with granulocyte macrophage colony stimulating factor, or GM-CSF. And that's the same compound that Provenge uses. So Provenge just takes GM-CSF and connects it to prostate-specific antigen as a protein, and they stimulate essentially all the cells, or try to stimulate your dendritic cells in that process. So we're using the same, what's known as an adjuvant, or something that will help stimulate an immune response in this therapy, and they were given in both cases. So we were really thrilled by this response, because that means we weren't just lucky, and that these patients didn't just do this well. In fact, these two curves right now are trending really close together. We're about 2.5 years out of median follow-up. That means half the patients have been followed for 2.5 years. We're still waiting for the development of the results, but we're really pleased with this kind of therapy. So I thought I'd just quickly, in the few minutes I have left here, go through one of the more amazing responses. So this is a 59-year-old female educator, and this is why we're so excited about using this type of therapy, and why we want to actually approach other disease types. So she presented with routine neurologic exam due to pain, and it turned out that she had to have surgical debulking of the C3 to T1 mass, and turned out to be melanoma. So she had diagnosed with spinal melanoma. She underwent PET-CT, detected lung and rectal metastases. So she had metastatic disease to visceral organs. And then she completed radiotherapy and resection. So we were able to actually get this sample and start growing the cell line. She progressed, had 2 more brain mets, which went to Gamma knife. So this is about a year later, or not a year later, about a half a year later. So she's got brain mets now too. So she had lung and rectal, and now brain mets. She completed 4 cycles of high-dose interleukin-2. Then in July of that year, she had resected her gallbladder and abdominal wall. This is actually, her entire gallbladder was replaced by melanoma. And then in September of that year, had new disease in the abdominal wall, and the gluteus, and a breast nodule that were measured by CT. And then in November of 2007, so this is a little over a year after her first diagnosis, she started our vaccine and the DC-TC cell therapy. So she was on that DC-TC arm. And in October of 2008, about a year later, the scans confirmed decrease in metastatic disease. And then in January 2009, she had no evidence of disease by scan. She was in complete remission. And as of January of this year, she remains free of disease greater than 4 years from the start of vaccine, and greater than 5 years from the original diagnosis, having never been disease-free before. So it just is remarkable, because if you think about it, she started with just a lot of different disease, a disease recurring even after therapy. So she was never disease-free, and then she went on this dendritic cell therapy that was potentially anti-metastatic, anti-cancer stem cell, and she's disease-free today. So it's really a very remarkable result. And I mean, I could go through the scans, but I think I'm probably running out of time. But here's a little nodule here that goes away. Oops. There's one here in the breast that goes away. This is more clinical, but there's one right there that goes away. So what other disease, what other tumor types are we thinking of approaching? Well, there's a whole list of ones now that we're starting to see cancer stem cells being found in. The technology of growing the cells is becoming more mature. It's getting easier and more viable to create these cell cultures for cancer stem cells and expand them. So that's my forte now. And so one of the ones we want to approach is prostate. We're also interested in doing ovarian. Of course, we've done melanoma. And then, of course, these other tumor types like brain and breast. So if you remember that first slide I showed you, the hallmarks of cancer, and that diagram of those different characteristics, these are the ones shown in gray. Well, Hanahan and Weinberg actually updated it in 2001 to start including some of these other aspects of cancer biology. So one of them is deregulating cellular energetics. That's essentially how the cells use energy. They figured out a way to use less energy. Genome instability and mutation, the ability to basically mutate and find ways around therapies and become refractory. And then tumor promoting inflammation. Essentially, cancer has been described as the wound that never heals, and this is part of that property. The idea that your body's own natural healing and immune abilities actually works against itself and promotes tumor formation and tumor metastases. And then avoiding immune destruction. So this is where we are. We're here trying to get these cells and get them so they can be destroyed by our immune system in a way that's non-toxic and lasting. And then this is just the different kinds of technology advancements we've had in all these different areas. So the world of cancer research now, because of the kinds of things we know, it's kind of like a shooting gallery where you go in and you shoot down the little targets with a BB gun at the fair. We're starting to shoot down some of these targets, and we're starting to find new ways of getting at these targets, and it's really quite remarkable. So I'll leave it with that. And I actually have this slide up right now because I'm actually, tomorrow, I'm leaving to go on a cruise to Alaska. So I love this slide.
Tomorrow you're going?
Tomorrow, yeah.
Tomorrow?
Yeah.
Wow. So we don't want to keep them too long here, but I do want to I do want to open them up to questions. If anybody has a question, please come on up here. We'll give you the mic. We'll let you address the question to them so that we can get the answers on the DVD. Nobody needs to get their face seen on camera, but come on up here if you have any questions for Dr. Cornforth. Now I think you can see why the papers that he wrote and the topics that he wrote, why I couldn't really give them to you here because they went way over my head. But anyway, Dr. Cornforth simplified it for us here. One question I have, Dr. Cornforth, while I'm giving people a chance to come on up, and come on up, folks, anytime. Are you having any problems with religious people in your research?
Because of the aspects of embryonic stem cell?
Because stem cell, everybody says stem cell is a human or a life.
Well,
you can use your mic, please.
I'm sorry. Hello. I'm new to the company, but I have heard there have been some issues. Ethically, our company and the use of embryonic stem cells, these are donated cells. So the process of the donation is very ethically driven. And someone is giving up frozen embryos that are going to be discarded anyway. They actually go ahead and say, I want them discarded, and then after they say they want them discarded, they're offered the ability to donate them if they want to. And the cell lines we're using now are all derived. We've already made them all for any of the studies we're doing. So we're not actively taking in new embryos all the time just to keep the cell cycles going. So we've developed these cell lines and we keep them in the laboratory. And we grow them up into really large numbers, and we basically make them become a spinal cell or a hepatocyte or something, and then we store them that way. So they're ready to use. Yeah.
Thank you for your discussion here today.
Thank you.
It was my impression that you're in the feasibility proof of concept phase in regards to working with prostate cancer. So the question is, if that's correct,
Yes.
what would your goal be in terms of going to a phase 1 opportunity if your feasibility turns out positive?
What would a timeline look like, maybe?
Yes.
Well, we're working on the grant proposals right now. So we need to fund the program to be able to do the optimization, which shouldn't take a significant amount of money, so it should be fairly easy to do. And then we would take that data and probably submit for a phase 1 study, which is considerably more expensive when you're dealing with treating patients. But my prediction is it'll probably take a year from the time we start doing the feasibility to actually optimizing all the conditions and making sure we can gather these cells from patients and grow them in a significant number. So I don't expect to get everyone to have a cell line that grows. I would be happy with 30 to 50% of the success rate in terms of getting cells and growing them. But after that, then we would submit and say, okay, now we want to go to a phase 1. I would say it's probably a year after that, so 2 years away.
Thank you.
Sorry.
How about phase 3 or 4?
Well, it all depends on what happens in phase 1. Now, like I said, if it's all based on the melanoma program, we've seen nothing that indicates there's a safety issue with this at all. So we could almost convince the FDA, look, these are the cells we're using. GM-CSF, dendritic cells, whole cell vaccine. There's no safety issues here. We're not putting in a virus, we're not putting in a drug. Can we just go straight to phase 2 and try to skip the unnecessary step of the safety and dose-limiting toxicity settings? That's what a phase 1 is you just give them more and more until, well, I can give you probably, 100 million of these cells, and your body is just going to go, well, it's not a toxin to me, so it's probably not going to be a big deal.
About 5 years?
It all depends on the optimizations at this point. That'll drive everything. How quickly can I get it optimized to be able to get the cell lines to grow at a reasonable amount of time? But I would say 3 to 5 years. Yeah.
We have someone who has inoperable brain tumors. Can this technique be applied to that?
Well, unfortunately, no, because we need to do the operation to get the cells, to develop the cells in culture to make the vaccine. We also, at Hope, we also had a study going where we used lymphocytes. We would take lymphocytes from a patient and we would activate them in the laboratory, and then when they had brain surgery, we would take those activated lymphocytes and we'd place them back in the brain. And that was the only study we had like that at the time.
So you have to get the cells right at the source.
Mm-hmm. Yeah, there is a group, Northwest Biotherapeutics, that is doing a study that's similar to ours, where a patient would undergo surgery, they'd have to have surgery, to get tumor cells to use to load dendritic cells. Now, they don't go through the process of purification, they just take the whole thing and make it into basically a protein-based structure, they're not whole cells, and they put it back in the dendritic cells and use that. That's the closest thing that we'd have right now with immunotherapy for patients with brain cancer. Yeah, and they're in phase 3 right now.
Thank you.
Mm-hmm.
Anybody else, because before we ship him off to Alaska? Okay, I know some people like to trap our speakers with personal questions. I'd like to ask your respect with Dr. Cornforth in this point because he is trying to get out of town. So if you have any questions, we'd like to have it now. Otherwise, leave him alone, let him go. Thank you very much, Dr. Cornforth.
Thank you. I appreciate it.
We appreciate your talk.